Hello, I'm Deepak Bhatt, reporting for ACC.org from the European Society of Cardiology in London, and it is my great privilege to have Professor Keith Fox here with me to discuss some of the latest, greatest trials that were just presented. So perhaps we can start off with a discussion of some hypertension trials that were presented. Some really great data presented here about hypertension, and specifically resistant hypertension, a topic of great interest.
Sure, Deepak. You know, the critical issue is how much resistant hypertension, truly resistant hypertension, is out there,
right,
and which therapies are needed to define truly resistant hypertension. So there have been two key studies presented at this meeting, Pathway 2 and Pathway 3. And in essence, what they're looking at is whether the addition of spironolactone is going to have an impact in terms of the final definition of resistant hypertension.
Right, and spironolactone looked great in the Pathway 2 trial where it seemed like resistant hypertension melted away in the majority of patients.
Yes, I mean, essentially what it's saying is that there is an absolute difference of about 8 millimeters against placebo on top of baseline therapy, and against one of the active comparators, about 4 millimeters additional benefit with spironolactone. So the message for the cardiologist, the message for the general physician is don't diagnose resistant hypertension until you've tried spironolactone on your patient.
Absolutely, that's something we learned in the Simplicity 3 trial as well, that when patients were started on spironolactone, a lot that came in with the diagnosis of resistant hypertension went out without the diagnosis. So
Sure.
An important trial that now has nailed down spironolactone's value in that setting.
It has. Carefully conducted and defined in terms of the long-term outcomes. We've got to talk about the issue of whether thiazides are hazardous in terms of glucose.
Yes.
And that was addressed in Pathway 3.
Right.
Because you know there's concern about elevations of glucose
Yes.
with thiazides, and the question is whether amiloride might attenuate that or avoid that problem.
Right, and amiloride is a drug we don't use so often in the US anymore, but it looks like from this study that amiloride is perhaps superior to hydrochlorothiazide with respect to metabolic parameters, and that the combination of hydrochlorothiazide plus amiloride was particularly favorable in terms of reducing blood pressure.
So here's a generic drug. Yes, it's not used very widely in the US, but it is widely used elsewhere,
Right.
and it's avoiding the hazards of elevated glucose that occur, and highly relevant for, you know, an elderly population.
Absolutely, so two good studies about blood pressure, one specifically resistant hypertension and the other a broader population.
Sure. And so perhaps we should move on to the issue of dual antiplatelet therapy. There's been a lot of debate in the community about duration and risk versus benefit. So at this Congress presented a French study, Optidual, that's a clopidogrel plus aspirin versus aspirin alone, 12 versus 48 months.
Yes.
And this was all comers, it wasn't post-ACS. So what are your insights on this?
Right, so an interesting design, a good design, a little under 1,400 or so patients, post-DS, so it's not specifically a ACS trial, it's a post-drug-eluting stent trial. And the overall endpoint of NACE, net adverse cardiac events, was lower with 48 versus 12 months, but that wasn't statistically significant, so you could say the primary endpoint was missed. But for MACE, the triple ischemic endpoint, there was a trend, p-value of about 0.06 for a lower rate with 48 months versus 12 months. So, certainly suggestive that longer is better, but strictly speaking, the trial, didn't meet its primary endpoint.
And they didn't detect an excess of bleeding events.
Yes, very interesting. Though again, one could argue that both for MACE and bleeding, it may have been underpowered.
Yeah, a bit charisma-like?
A bit like it, but with charisma, I think it did lend us some insights, and of course you and I were both involved with leading that trial, but what that study, of course, showed was that in high-risk secondary prevention, in particular post-MI patients, there did appear to be a benefit. And, at this meeting, actually, there was a meta-analysis presented where we built upon those findings and pooled several relevant subgroups, including the Charisma post-MI subgroup, including the DAPT trial ACS subgroup, including Pegasus, not as a subgroup, but the whole trial, since that was a post-MI trial, and 3 other smaller studies as well, and found a significant reduction in MACE with longer durations of DAPT versus, say, just 12 months or so. And beyond that, which is largely confirmatory, there was also a reduction in MI, that's expected and known, but a reduction in ischemic stroke as a standalone endpoint, but also a reduction in cardiovascular death as a standalone.
Cardiovascular death. So this is the first time, by pooling all of these together, that there's really a clear signal in terms of cardiovascular death.
Absolutely. So that is certainly supportive that in post-MI patients who are otherwise high ischemic risk and at low bleeding risk, such that they enter a clinical trial. But in that type of carefully selected population, a longer duration of DAPT did seem to be better.
So that's really an important take-home message for the clinician, and it really shows how combining the results of individual trials can give us some additional and important insights into this balance between risk versus benefit.
Absolutely, and I think it makes sense because in a post-MI patient, they've already had an MI, they've ruptured plaque, they're probably more prone to do it again. Makes sense if somebody's going to benefit from protracted DAPT that would be the patient. Well, hopefully this review of trials was useful to all of you back home. Professor Fox and I are having a great time here in London. I hope you enjoyed this segment.
Thank you.